Welcome back to The Outer Shell, a podcast from Covalence Health, where we peel back the layers on issues that actually drive healthcare in this country. I'm Mike Rawan, founder and managing director at Covalence Health, and your host. We're back from summer vacation, and we're ready to hit the ground running. In our last two episodes, we talked a lot about value-based care, why it matters, what it demands of providers, and what it actually takes to succeed in a risk environment. Episode 2 made a specific point that I want to pick up on today. If you want to win in value-based care, you have to know your population. You have to practice prevention. You have to understand who your patients are before they show up sick. But here's the problem. Most of the tools providers use today to understand their population are fundamentally broken. The models are wrong, the data is incomplete, and the assumptions baked into most healthcare analytics would get laughed out of a graduate level statistics course. So today, we're going to talk about why and what to do about it. My guest today has spent 20 years working at the intersection of data science, economics, and healthcare. He is a principal at InfoWorks, a Nashville-based consulting firm where he leads the value-based care analytics and outcomes practice. He holds a PhD in environmental and natural resource economics from the University of Tennessee in Knoxville, 2 master's degrees, and is the author or co-author of 17 peer-reviewed publications. He has designed quasi-experimental studies, built machine learning models, and worked hands-on with providers and payers trying to figure out whether their risk contracts are actually generating value or just generating paperwork. Dr. Aaron Wells, welcome to The Outer Shell.
Thank you, Mike. Thank you for this opportunity.
Well, Aaron, here's a perspective I want to put on the table. I want you to either push back, agree, or sharpen it. We've spent the last decade in healthcare building analytic infrastructure, EHR data, data warehouses, population health platforms, claims risk scores, predictive models. The investment has been enormous, and we've gotten genuinely better at one thing, counting what already happened. We are excellent at the retrospective analysis. We can tell you exactly which patients were admitted last quarter. We can rank order members with HCC scores or by HCC scores. We can produce a beautiful dashboard showing that your diabetes management program enrolled X number of people. What we're not good at is prediction, not real prediction, the kind that actually changes clinical decisions before a patient deteriorates. And I think part of the reason is that the models we rely on were never designed for the question value-based care is actually asking. And I believe that question is, which patient is going to need me before they know they need me? And that is not a claims question. That is not even a population question. That is a question about a specific individual, their biology, their behavior, their environment, their support system. And most of our models answer a completely different questions. They answer, on average, what does a patient who looks like this will cost? My position is this: the statistical infrastructure we build for fee-for-service, which rewards treating more people and billing more units, is the wrong foundation for value-based care, which rewards keeping people healthy. And until we get honest about that, providers are going to keep signing risk contracts that they don't fully understand, using models that they can't tell them what they actually need to know. So, Aaron, you've done this work at the ground level. Is this diagnosis correct? And if it is, how do we get here?
Yeah. Well, I've thought a lot about this particular question. Yeah. And thank you for this opportunity and really the comprehensive set of topics we're going to talk about today, this being the most foundational. Being at the ground level for more than 20 years now, ground level meaning I work with claims day in and day out, claims eligibility, EMR fees, ADT, and have been doing that for decades. What I have noticed over time is that you do need to move forward with the way that you're utilizing this information within an econometric or statistical foundation. And when you do that, you develop these forward-looking risk predictions of not just the individual, but across individuals within a population. And where I think I would agree, our retrospective reporting is quite good, but that's easy, right? These events have already occurred, something we touched on. What's not easy is understanding the future and understanding the factors that are driving the future for each individual and then across the population. Our statistical models have significantly improved. We now have much more sophisticated models available to us. We have better computing power now with the advent of AI and availability of it. We have the ability to look across multiple different data platforms and models to generate one consistent view of an individual. This was very arduous in the past. With AI now, we can take in voluminous data with sophisticated models to derive that individual expectation. One last point on this, and this is where I spend a lot of time, is deriving an expectation. So value-based care is not retrospective, it's prospective. It's managing risk today to avoid the future risk that may have adverse consequences associated with it. That is where we are quite poor. And understanding how that future expectation of risk can then be monetized going forward now. So now we go forward, say 18 months, we now monetize the difference between what we observe today and what our expectation was 18 months before to then derive the payment that, say, a value-based care provider has. Just even saying that out loud, I'm sure most people attending this will say, I don't even really understand that. But it's true. We derive expectations of the future today. We then reconcile those expectations 18, 20 months later against what's been observed. And it's this timing mismatch, which is just very difficult for people to wrap their head around. And when you're in the moment and having to reconcile an expectation derived 18 months before, you're like, well, how did you not know this was going to happen, or these other events? And it just becomes this complex myriad of factors that have to be accounted for in a reconciliation, and retrospective reporting just simply doesn't do that.
Yeah, you are opening some wounds here for me, my friend, or at least triggering some PTSD. But let me get specific here. When you look at the statistical models most commonly used in healthcare, risk stratification models, cost prediction models, clinical quality algorithms, what are the most consequential flaws? Not the theoretical ones, not the academic ones, the ones that actually cost providers money and, even worse, cost providers outcomes.
Yeah, if I could bucket this into two, maybe three categories of where these current risk methods are inaccurate at best, and worse, they're leading providers down the road that is not allowing them to properly manage risk, which means then they're not able to achieve the full gain share that is possible for them because they were not managing the right set of individuals or the right risk factors even within the individuals that they were managing. So the couple buckets I would say is, let's first look at the CMS HCC risk scoring model. I don't know what it is. It's some sort of bastardization of math and statistics and, I don't know, I guess actuarial science. I have no idea actually how that's an approved method for redistributing tax dollars to individuals who have supposedly risk adjusted a person. But it's linear math. It's made up in the, say the coefficient of determination, which I'm not even sure they'd report on the most recent risk score model, is less than 20% of the variability explained. That's how we're allocating or determining risk and then allocating scarce federal dollars across individuals. So that's the flaw. One, it's linear and it's made up math. We'll look at some of the other clinical risk factor models, which are more sophisticated. If you look at, Hopkins or was it United's ETG risk scoring?
Right.
Honestly, I don't even really see those much anymore. But those models, and I've spent time, especially with Hopkins back in the day, and it's a very good model, but it's still linear. It does not capture a lot of the factors that drive a risk that are latent. Latent meaning we're not observing them directly in claims. You need EMR. You need social determinants of health. You need people in the person's home observing what's causing or related to their inability to manage their health education, access, all these factors that are not directly observable, especially not in claims eligibility ADT feeds, and maybe not even in EMR. They require hands-on in-person contact. So if I were to say just two primary categories, one, we still continue to use linear models when we have very sophisticated econometric machine learning models. And second, we're not correctly or adequately accounting for latent factors that drive healthcare utilization.
Excellent. I love how you framed that. But I'd like to move from the diagnosis over to the prescription, if you will. If you're a provider organization, whether a health system, a large physician practice group, an FQHC, entering value-based contract for the first time, what data do you actually need to be looking at? Not what the contract gives you or what it makes available to you, but what do you actually need?
Yeah. And just, continuing with the last comment around latent factors, uh, you- if you're adequately going to manage risk, and adequately meaning, and that's kind of a blasé word, adequate. But in my experience, human beings are the most stochastic data generating models there is in existence. The stock market maybe could be next, or weather, but we are random individuals. We are random with respect to what can occur. A former boss of mine used to say bad things happen to good people all the time. He was a cardiologist and he had experienced that in his lifetime. And for me, that's what kind of drives me when I think about analytics, is how I need to be as good as I can possibly be. Not with just the tools that I use, like say using a random forest model as opposed to ordinary least squares, but the data that I'm utilizing and the features I build from that data. So one, if I'm only using claims or ADT feeds, EMR, eligibility, like bare minimum data that you have to have. But now what am I missing? What are those latent factors? How can I close that gap? Well, let's see if we can get someone in the home of the most risky people I expect to have bad, adverse events occurring. Can we get someone in the home? Can we conduct a qualitative survey, really understand those activities of daily living, the instrumental activities of daily living, social determinants of health, behavioral risk factors, what's driving them in such a way that they're not having that proclivity to change and readiness and willingness to change. Anyway, you really need to be thinking about the whole person. And even then, once you have all that data and you have these sophisticated models, that word adequate comes back up. Like, perfection does not exist when we're trying to derive an expectation at the individual level of future healthcare utilization. It's just not possible. But you're trying to understand as much as you possibly can about that person, and then utilizing that information in this, in an intelligent clinical workflow that balances reality with just even the experiential learning or understanding that your clinicians will have to help manage that risk. So basically, you need a lot of data, sophisticated models, and you need to be tied in with a strong clinical delivery model.
No, absolutely. I think that ties nicely into the next point I want to bring up here. And, this is the thread that I really want to pull on, if you will, because I think it kind of connects everything we talked about in our last episode with our mutual friend, Becky Baker, around the population and understanding and really truly knowing your population. Becky made the point that providers who succeed in value-based care are the ones who can walk into a care coordination meeting and talk about specific patients, not the cohort, not the risk tier, but hey, Mrs. Johnson in room 4 hasn't refilled for metformin in 3 months and whose daughter has just moved out of state. So what can we do for her? So how do we get to a point where data can tell that kind of a story? Because most analytic tools are designed to give you a list and not necessarily a narrative.
Yeah, and this one's tough because Becky is a very good friend, and I know she was on the show recently. When I hear that particular example or use case of data and analytics, I just struggle with the practical realities of it. If you're managing thousands of patients, again, we're stochastic data generating individuals. So bad things happen to us, or there are things that are occurring that we do not know. It can be very difficult to pinpoint Mrs. Johnson, very difficult. And to know that her daughter is no longer able to support her. The metformin, sure, we could probably know that, but, and tie it together with other factors. But So I've had the opportunity, very, very fortunate over most of my career, to work directly with the clinical delivery teams, to work with the CMOs, and to work with all the people who are supporting them in their patient engagement. They are having those types of meetings. The problem is you have scarce resources, human resources, to deploy across your population. Decisions have to be made, just like they do in the operating room or any other situation where you have to decide what's the most important factor to or set of individuals to focus on. So I do see it. It is happening. I do see data being utilized, data from people like me being utilized by CMOs and their teams. I just not sure if enough of the latent factors, what's happening in the home, what's happening with the daughter in this example, is being carried into the more objective analytic perspective that is brought into those CMO type discussions. A lot of the people that I work with have no idea about the social determinants of health or these other factors that are driving healthcare utilization. We all talk about it, but I don't see a lot of my peers using that information. In fact, I just had a call yesterday with an actuary who made an astounding comment, actuary from a prominent health plan, made an astounding statement that they're worried that if we reduce admissions too much, they're going to start losing on their risk adjustment because they're not able to capture the diagnoses through admissions. Yeah. And it's just like, are you kidding me that is actually where a health plan will now focus their time, is finding the balance between admissions and diagnosis capture for risk adjustment. Which means, by the way, Mike, nobody gives a crap about Mrs. Johnson's daughter not able to help her, which is actually going to result in a bunch of other bad stuff happening. All this to say, it is an evolving field of how do we pull in a sufficient level of information at the individual level across the population, apply advanced analytics in such a way that we can deliver as analysts information to those delivering care in a manner that results in that better care being delivered before it needs to be delivered.
No, that's a great point of view. And I think it's kind of meeting Becky in the middle in terms of what is available to us right now. What can we realistically do to empower clinicians to make the right decisions at the right time? I do want to kind of push back a little bit, right? Because I think the harder problem is underneath everything that you just described. Everything you're talking about requires good data, better attribution, richer clinical records, SDOH integration, longitudinal view of the patient behavior. The data infrastructure requires time, money, and technology partnership that most community hospitals, independent practices, federally qualified health centers simply don't have. So my concern is this. We are essentially telling small and mid-sized providers that in order to survive value-based care, survive, not succeed, just survive it, they need to become data science organizations. And most of them are barely surviving as clinical organizations. So is there a version of this that works for a provider who doesn't have the data team? Or are we describing a future where only organizations that can actually succeed in VBC are the ones with the capital to invest in the analytics infrastructure, which mostly means large health systems and private equity backed groups? Because if that's the future, the policy implication is significant. We are designing a payment system that rewards sophistication over access. And in my opinion, that is a problem.
Yeah, I think I'm going to be mixed on how I respond. Mixed in terms of supporting what you're saying and disagreeing a little bit. As an economist, I do actually see this as what you're describing is what is happening and what will occur. The small to mid-sized providers will eventually go away. They just will not have the time and money resources to accommodate the amount of data, the analytics to give you that prospective edge to manage risk before it manifests. I would completely agree. That is what's happening. But we see that throughout our society. In a free market like what we have, this is how you advance. You kind of, unfortunately, those who cannot succeed, who don't find the efficiencies, who cannot compete in the new environment, just get shut down. So we saw that. I'm an environmental economist by training. That's what we saw with, heavy polluters. we tax them enough, or we create pollution exchange trade markets where, unfortunately, if you're not able to adapt your system, your production system in such a way that you can be emitting less pollution, you pay a fee. And eventually we're going to shut you down. This is how free markets are designed to work in one particular way. That will happen in healthcare. What I am seeing as an encouraging trend is that for those small to mid-sized providers where scale matters, because you have to have enough lives to generate enough gain share to pay for the technology that's required to achieve population health. I see health plans, a lot of health plans, and I'm very lucky to work with many of them across the country and have been for decades. They're leaning in, Mike. They're leaning in. They're giving them the tools. They're starting to give them the data that they've held so tightly. This is how those small to mid-sized providers who should, in a free market, moving to value-based care, be shut down. This is how they're staying afloat, is that they're being given the tools and the opportunities to succeed. But for those providers who are slow to accept that, or even make some fundamental minor changes to the way they practice to accept this new data and this new way of thinking about patient risk, well, they will be shut down. And that's the intent of value-based care. We need to find the highest quality, most effective, efficient providers, because we do not have the workforce to support the coming tsunami of risk that we're already starting to see a little bit of as we continue to age in this country.
That's a great point. And I want to come back to that in terms of the payer-provider relationship. But you alluded to something that's really piqued my interest, and that's where I want to go next. You came into healthcare from environmental and resource economics. You didn't start your career trying to fix claims models. You started it thinking about how ecosystems respond to intervention. And I find that fascinating. Because one of the things that bothers me about how healthcare analytics is taught and practiced is it imports methods from fields that have very different assumptions, fields where you can randomize, where the data is cleaner, where the population doesn't self-select in or out of your observation window. So what does your background in environmental economics actually give you that a standard health outcomes researcher might not have? And what does it mean for how you approach a problem like this? Is this value-based contract actually improving health?
Yeah. Honestly, and of course I'm biased, I have found it to be incredibly useful when I'm having discussions with, say, traditional actuaries, of having this environmental econ background. At first, when I started my career in healthcare, I thought it was going to be a limitation. And by the way, I entered healthcare. My wife was moved down here from Washington, D.C., a couple decades ago, and I had to switch careers. Back then, remote work was not possible. And as an environmental economist, there were no jobs here in Nashville. So I switched into healthcare. That's where you and I crossed paths at Healthways. I entered Healthways, had to start my career all over, PhD, 2 master's degrees, multiple publications by this time, late 20s, as just as an analyst. But Healthways, what they saw in me, and they're such an innovative firm, was this ability to take these econometric methods, at the time, econometric methods that were approved for monetizing externalities within an environmental setting in a formal or litigation context. So these are methods that can withstand legal scrutiny. I took those methods into Healthways. Again, very fortunate to be at the right place at the right time, of now moving from a chronic condition management focus, fee for service, into being paid for value, for creating a situation or like a set of population health outcomes in the future that were better than what we expected them to be. So you have externalities, you have expectations, you have methods to monetize. This is all normal for environmental economists. In healthcare, we're just now starting to understand how complex it is to do or to monetize value-based care, because it primarily focuses on an expectation, not what we directly observe. This gets all the way back to your very first comment. We've lived in a retrospective reporting world. We care about risk adjustment, which happens through sweeps and some other complex process, months and months, if not potentially a year after the event. Well, that's completely different. We're now deriving an expectation of the future based on data we have from the past. Going forward, then to reconcile that past data used to derive the expectation to the current. Like just even saying that out loud, it should be very confusing to people, but this is what value-based care is. Where I struggle with actuaries and health economists who do not have the kind of training around externalities, expectations, the influence of models, is that they're linear thinkers. They believe that a linear combination of HCCs adequately captures risk. There's nothing in life that is linear, by the way. Second, we're missing all those variables that we talked about, latent variables. So I developed Parallel Health. It's a software product, not pitching it here, just saying that the reason why I developed the software that I have is that no one is doing this in a real world evidence setting for value-based care outcomes. There are firms that do this, for other applications, but to do this in a healthcare setting where you have to derive a set of contractual set of parameters around expectations and complex modeling and externalities and variance. This is nothing that's being taught to actuaries. Right now, they may know one method called propensity score matching. There's so many other methods combined with data. And for me, I've been very, very fortunate, Mike. Healthways was a great place that fostered such innovation, brilliant people like you that, it was a great place and a great time. And now I'm seeing the benefits of it and couldn't be happier to start to slowly see the industry move towards understanding the complexity that is value-based care.
Yeah, I couldn't agree more about Healthways kind of fostering that innovation and, almost an innovation mindset in all of us. And that's kind of where I started nerding out over data. So I absolutely, once again, love how you're taking something that's outside of healthcare, doesn't really look like healthcare from just an operational structure point of view and applying that into healthcare. And I do think that brings such a unique perspective and it's a positive one in my mind. And feel free to pitch the product because I think it's a great product. I think it absolutely deserves to be out there. So no hard feelings or worries there. But let me just kind of put the operator lens on and kind of bring things down to earth here. If you're a provider organization sitting across the table from a payer who is offering you a shared savings arrangement or even a full capitation deal, before you sign anything, what are the 3 or 4 data questions that you should be asking? Not about the contract terms, but about the data itself. Because in my experience, and I've been on both sides of the table here, the negotiation around contract terms gets a lot of attention. The negotiation around data quality, data access, data methodology gets almost none. And that's where I believe providers get hurt.
Yeah, I completely agree. And touching on an earlier point, I do see health plans leaning in now. I really do. It's been just in the last couple of years, have I seen this kind of collaborative approach. Prior to the last couple of years, Mike, it was very difficult for a provider group, unless they were a sufficient size, to have the claims data on a regular basis, eligibility on a regular basis, pharmacy on a regular basis, let alone ADT and EMR feeds, right? That for GAD and PHQ, that was never going to happen. But now I'm actually seeing health plans providing this data. So I'm saying what I'm saying right now is not something I would have said earlier. I actually see that providers, when they ask for claims data, they are able to receive it. Now, interestingly, I work across many different disciplines: women's health, behavioral health, polychronic, pediatrics. Behavioral health continues to struggle with plans realized or understanding why they need claims data. So that would be the one discipline of all those, 5 I think I mentioned, where claims data just are not coming in. And I don't know what it is about health plans, and this is multiple health plans that this one particular behavioral health firm that I work with, who's national, they just cannot cross this boundary with them. So we actually have purchased claims from Criteria Labs. We're going to publish a paper here soon around how effective they are at managing risk. And by the way, they had to go buy all these claims because health plans aren't giving them the claims. So hopefully this will start to help the behavioral health firms and payers realize that they need this data. Okay. So you've got to have that, because what that does with claims is it gives you the longitudinal retrospective history of a patient, total cost of care, no matter where they went in the market. Anyone in a health system understands and appreciates how important knowing the total cost of care is, because most health systems do not know where their patients are going outside their system. So you have to have claims for that retrospective longitudinal record. EMR, EHR data now is becoming much more available through QNs. That's been very, very exciting advancement, by the way. I would also give a big heads up or a thank you to the Tuva project. A lot of the firms that I work with are using Tuva. It's been a game changer on the data engineering side of things. It actually gives the small to mid-sized providers a real chance. ADT feeds, Mike, would be another one I would put on there, that you have to know when for the transitions of care, when a patient's gone in and out of the hospital. After that, it really is on the provider. Stop thinking about what the payer can give you. Get the GAG, get the PHQ, ask some questions around behavior change. There are many different survey instruments out there around the proclivity to change, readiness to change, willingness to change, how we keep that change. You have to think about a patient holistically, not just the objective transactional, what happens in the healthcare ecosystem, but what's happening at the home, what's happening with the behavior change, what's happening with their perception of their own health. So it's a mix. Yes, ask the payer for what you can, put data quality standards on that, meet monthly, have QA reports, counts and amounts, checksums, very basic stuff. But also you have to hustle. You have to get out there and you have to collect this data, and you have to integrate it in a way that makes informed decisions around each individual and across the population. Which,
Great.
unfortunately, my last point gets back to, yes, the small and mid-sized firms that do not build the infrastructure to take in this kind of data, analyze it, and yield individual level predictions, unfortunately, you're not going to make it, in my opinion. Okay.
No, I think that's a great perspective, because it is a bit of, meeting in the middle, if you will. So, along that point, let me kind of flip the script over here and on the other side of the table, right? So if you are a payer, right? So from the payer's perspective, and you're listening to this and you work in Medicare Advantage, managed Medicaid, or commercial value-based arrangements, what should you be doing differently? I mean, you talked a little bit about this, is that they're opening up in terms of sharing more more data with providers. What else could they be doing?
This is a little bit subjective, Mike, so hopefully it's okay. But
Of course. Yeah.
in the last couple of years, what I've seen, when I say payers are leaning in, health plans are leaning in, they're actually showing up to these reconciliation meetings or these prospective meetings where you're developing the methodology that we'll use 18 months later to reconcile outcomes. They're actually showing up saying, let's talk about these methods. Let's talk about how we want to think about risk, whether it's HCCs or course exact matching, risk score matching, some sort of forecasting out. Let's understand how we quantify risk today using historical data for the purpose of prospective risk expectation generation, because that expectation is how we're going to monetize your outcomes and pay you 18 months from now. So it's just like this general understanding that this is a complex problem without a commercial single solution. CMS may say HCCs are it, and everybody has to play by their game or by benchmarking, the benchmarking method. But for anyone in the commercial sector, benchmarking, the CMS benchmarking method and HCCs, they mean nothing. They have very little consequence in these types of discussions. So where I see it, Mike, is more on the subjective side. Health plans are leaning in to help providers understand just how complex it is, in giving them human resources and tools like Parallel Health to help them understand that risk. But that is supplemental to more data being provided and some of these other ways that on a policy front that health plans are leading in. I'll just say, hey, if you had asked me that question 3 to 5 years ago, you would have had an ornery response that you probably would have edited heavily, because passive payers were not the most friendly. I cannot be more excited about what I'm seeing. It is truly a transformation that I get to see on the ground level with a lot of startups, mid-sized firms. I don't work with the biggest firms. Those are for consulting firms that are much bigger and more prominent than me. But I'm excited, honestly. I actually don't have any negative comments anymore about the health plan space. It's been really exciting.
And I agree with that. I think 3 years ago, if I would have asked that question, it would have been probably at a more frustrated tone. But I'm just as optimistic as you are in terms of the evolution that we're seeing with how more willing the plans are in terms of sharing that data. But to your point, the providers kind of have to meet them in the middle and understand what they need to do with that data. And the point you made about sort of having that discussion, that collaborative discussion around the methodologies and how we're going to measure things in whether it's 6 months, 12 months, 18 months, I think that is truly key. And that's one of the things that I continue to push our provider clients on is make sure that you're truly understanding how things are calculated before you sign that dotted line.
Could not agree more.
Yeah, so let's kind of bring this back home, if you will. This is the takeaway I'd love for our listeners and viewers to have. The model is not neutral. Every risk score, every cohort analysis, every benchmark your payer uses to evaluate your performance was built by someone who made assumptions about your patients, about your market, about what normal looks like. And those assumptions may not reflect your reality. And you don't understand the model, you don't understand it, you can't defend yourself when the settlement comes back around. It's just exactly what we just talked about. Value-based care is not just a payment model. In the last episode, we've talked about how it's a opportunity to redefine and redesign how you practice medicine, your clinical workflows, but it's also a data discipline. The providers who figure out before they sign the next contract, and they're the ones that truly understand what they're getting and what they're getting themselves into. They are going to be the one who are going to have the ability and the data and the information to establish those sustainable margins and have success in this type of environment. The ones who don't are going to wonder why they're working harder and likely earning even less every year. So, Aaron, final words from you, sir.
Yeah, I think in that regard, as we move to value-based care, you do have to understand the economic model. That it becomes almost as imperative as understanding the clinical delivery model that you have. There are several firms here in Nashville who have experienced different forms of success in value-based care. Like, let's contrast Wellvana with Harmony Cares. Harmony Cares is blowing it out of the water, like in a very generic, coarse way of saying it, very uneducated way of saying it. People who just said that they're doing phenomenally well. They have a great leadership team. I know several people over there. Very fortunate to know a few people there, and just really love what they're doing. Now, having said that, they have the benefit, or they're working with a medically complex population. They have a lot of risk adjustment, which increases their baseline. Well, the higher your baseline, the more opportunity you have to influence the go forward situation. If you're working with a general population, with people who are not spending very much on healthcare, whose risk is latent and will manifest later for some, like Wellvana, that's very difficult. Now you run into very significant issues where you think you really do have one of the best clinical delivery models. You have a phenomenal IT team who's brought it on, but you're still managing a general population. It's just so interesting. So if you were to step back, Harmony Cares is doing extremely well. It's not the top provider ACO year over year, definitely top 3. Then you have Wellvana, who has mixed results, still doing well, but mixed. I think about those two firms all the time when I talk to providers, because it's really the population that you're managing. And if you can capture the risk within that specific contractual setting, if I were to take the Harmony Cares population and have to manage that in a commercial setting where I don't get to ride the benefit of this ridiculous HCC method, I would bet they'd have a different set of financial outcomes. Wellvana, take them out of this crappy HCC model and put them into a commercial setting, I think they would have a different set of outcomes. So it absolutely matters, the financial mechanism by which you're being judged, because both firms have phenomenal clinical delivery models and phenomenal leadership teams. So why are they paid differently? Anyway, I just very excited about what's happening. very much appreciate the opportunity to be here and to opine on these matters. And anytime if we could do this again, I'd love to be a part of it.
Well, I appreciate you, my friend, and appreciate you bringing the rigor and the real talk today. It's been an absolute pleasure to reconnect with you and talk data. I'm like a kid in a candy store. Got a data nerd talking to a data scientist.
Awesome. Well, thank you, Mike.
My pleasure. For our next episode, we are going to stay in the provider and value-based care space and have an in-depth conversation about how ACO organizations have shaped value-based care. We're also going to talk about what key partnerships are essential to succeeding in value-based care and what does the near-term and long-term future look like for value-based care. If you're a provider organization, a health system, or a physician groups considering value-based arrangements, you will not want to miss it. I also encourage health tech organizations and health services organizations who are trying to partner with value-based care companies or with value-based care providers to tune in because I think you'll find it very beneficial as well. If you found today's conversation helpful, please subscribe wherever you get your podcast. We're available on YouTube, Spotify, and Apple Podcasts. You can also follow us at Covalence Health on LinkedIn or visit us at www.covalencehealth.com for more insights, tools, and resources. Once again, I would like to thank my guest, Dr. Aaron Wells, and for all of you listeners out there for tuning in. I am Mike Rowan, and thanks for listening to The Outer Shell.